that don't realize that you can get Hep C by sharing dollar bills and straws and intranasal drug use. And I always try to explain that to the patients when they come. Go ahead. I'm sorry. Tattooing, you guys know, ever being in prison, having HIV infection should be a prompt for you to test. So again, this is what we just said, to summarize it on one slide. Hemodialysis is also a group. And in fact, there's some guidelines that suggest that with a hemodialysis patient, you should be checking a viral load because you can't rely on the serology. But I have yet to convince our nephrologist to do that. All right. So to kind of give you the dates of the blood transfusion, if you had a blood transfusion or clotting factors before 87 or an organ transplant before 92, obviously people with needle stick exposures or healthcare workers or finally anyone who has unexplained increased LFTs, Hep C testing is certainly indicated. Infants born to infected mothers, they should be tested at age 2 to 6 months with a viral load, or you can wait until age 15 to 18 months and test them, antibody testing, at which point you should be testing the baby's antibodies, not the mother's. And there's about a 2 to 5% risk of transmission. You don't lower it by C-section. If anything, it may increase it a little bit. And breastfeeding is okay as long as the mother doesn't have fracture bleeding. I just want to throw this in because I think it's not in the guidelines, and I'm going to say this is my own little part of this. It's not, but I think that you'll see why I decided to include this. I don't know if any of you are familiar with this device. It was a multi-use nozzle jet injector gun. I actually was vaccinated with one of these when I was in first grade. I would say that this was a great thing because it let us get rid of smallpox. But you don't get something for nothing. And it was used in the military all the way up through 1997. There we go. So here they are lined up getting their vaccines. And look what they're doing. They're taking one to the other with nothing, as you can see. So guess what happens? Thousands of veterans have probably been infected with, exposed to either B or C. This is still being contested, but guess what? About a year ago, the military decided they were just going to treat everybody for Hep C because they're getting so many lawsuits. Same with Hep B. It was even more important, I think, with Hep B. This gentleman right here, his wife actually sued the military. She was a big advocate, and he died from hepatitis C. And I think that's what really turned this around, was that she was such an advocate to get the military to start testing and treating Hep C. So I couldn't resist. I had to throw it in there, sorry. There's the VA testimony about it right there. So 1 in 5 vets in the Vietnam era were having hepatitis C. That's a lot. Okay. Okay. Now, I want to spend a little bit of time on this because this is where it really affects you guys. This is where I think this really is going. This was a paper published this year in Infectious Disease Clinics of North America about how, in one mode of how primary care physicians and providers started treating hepatitis C. This was done through what's called the San Francisco Health Network, which is sort of, what do I want to call it, a safety net for the city of San Francisco. If you don't have insurance or are homeless, this is sort of your healthcare system that you're into. And basically, these folks did a study where they showed that primary care docs could certainly treat Hep C, primary care providers, I should say. So this was what I'm going to give you their summary. But essentially what it boils down to is that they got if you look at the bottom there, they got a 3-fold increase in the number of patients treated for hepatitis C in primary care offices after they did their intervention. And I'll show you what their intervention was here in a second. It's not what we're going to be doing, but again, there's more than one way to do this. So they gave them a 4-hour training, and then they gave them this electronic referral system where basically they mailed in this, they electronically sent in this referral form, and then a specialist would look it over and they would make recommendations to them electronically. So that's how this worked. So basically this is what they did. They asked interested primary care providers to voluntarily participate in a 4-hour training session. They provided them with this e-referral form so they could submit the information, and then they would have their specialists look it over and get back to them. That was their design. This was their e-referral form. This is what it looks like. This is an actual block of what they sent them. So these are the questions they asked, and you'll see it toward the end of this talk. I think we have something similar that we're going to ask you guys to take a look at to see if you think it would be useful. So they ask, do you intend to treat the patient yourself? And then they ask if you've had these appropriate lab tests. And then they ask how good or bad their liver disease is and whether they've ever been treated before, which are all really good questions to try to answer. And so this is what they showed. So pre-intervention, there were only 143 people that were being treated in a 16-month period. That went up to 435 post-intervention in a 23-month period. The number of clinics that primary care providers were treating Hep C went up from 5 clinics to 12. So they had a large increase. Obviously, it's still not where you want to be because only about 19% of people got treated that needed to be treated, but it's a lot better than they were doing before. And by the way, San Francisco has a hepatitis C rate in our homeless population of like 2.4%. It's high. This, I think, is something they did that I think was really good. They asked the people that actually went through this, what were your barriers? And the number one barrier that they mentioned was getting prior authorization for the drugs. And I think at some point I'm going to try to ask some of our folks to come in and talk to you guys about that, because that is going to be a barrier that I think may be easier for us because we now go through UVM and they basically do most of our pre-authorizations for us, with a few exceptions. And hopefully that will be the case for you guys too. I can't imagine why it wouldn't be. So I'm hoping that we can eliminate that particular barrier, which was the biggest one in San Francisco. And the rest of this, good working relationship with the pharmacy. I think the biggest one was really the pre-authorizations. And hopefully you will feel comfortable after we go through these sessions that you really feel comfortable doing this yourself. Let me move on here. So this, did I miss something here? There was supposed to be another slide. Yeah, I didn't put it in somehow. So there was a slide too that showed basically a slightly different view of this, but basically the average clinic beforehand was treating maybe, out of the 5 clinics, they were treating maybe 1 patient. They were treating up to 4 patients at the end of this. And there were a couple of people that they called super users that were treating just like, they were up to like 15 patients in a couple of the clinics. I just missed that slide, putting it in. This is what I think we could kind of use ourselves. And again, this is not something that I want you guys to fill out, but I think it would be, what I'd like to do is actually put this on a Word, make it into a Word document, and just have you sort of do it as a checkbox for your own benefit. This is not to send back to us. And I'll talk to, so these are, I think, the 10 questions that I think should probably be answered on just about everybody that gets treated for hepatitis C. And number 1 is, could they potentially be acutely infected? You don't see very many people that actually are in the acute stage, so I don't really want to spend a lot of time talking about it today, but we will talk about it. But I would rather move on to the other ones, which is for everybody with chronic hep C. First of all, they have to have a detectable viral load. Remember that 20% of people clear it on their own, so you always want to make sure that they have a viral load. And then the genotype, we haven't specifically talked about them, but there are 6 major genotypes, and there have just been 2 more added, so we really do have 8, but around here we only see 1, 2, and 3. But genotype matters in regards to what you pick for treatment. Liver disease stage, we can talk about how to assess that. It's fairly easy. Whether they've ever been treated, drug interactions, comorbidities, co-infection. What I will say to you guys is what I envision this being like is like we can sort of screen out who you would prefer maybe to have seen at our clinic versus who you will feel comfortable treating yourself. What I mean by that is, say somebody has number 4, what is the liver disease stage? If they have decompensated cirrhosis, I would expect you would want to refer them here to us and not try to treat them on your own. Again, you can do what you want, but I would make that suggestion. If they were previously treated, I would say that would be one that you should probably send to our clinic. If they have, if they're a dialysis patient, or if they have decompensated cirrhosis, I would say those are ones you would probably want us to treat here. Co-infected patients with HIV or Hep B, at least for now, I would say send to us. Believe it or not, that's only going to weed out about maybe 10% of the Hep C patients, and the rest of them you're going to be able to easily treat yourself. But that's what I want to do. I want to sort of make it where you guys can go through that list and decide, should I refer or can I treat myself? Hopefully that makes sense. Okay. So with that said, I think this could be a nice point at which we could go and have our case and go down this list together with the case we're going to present and maybe use this and see how it works. Okay.
All right. Well, if everyone, again, will bear with me for just a second. We were recording that didactic, so that will be posted on our CVPH Echo exclusive WordPress site. So that link was included on the email I sent you yesterday, and I can certainly send that out again. I'm going to go ahead and stop the recording right now, just because when we do our case presentations, we want to make sure that we don't risk any kind of HIPAA breach.